Okay.
Hello, my name is Ijoma Ajayi. I'm a nurse practitioner student. Can I call you Mr. Obi?
Yes.
Okay. Just before we came in, I asked you to put on a hospital gown, but you prefer what you're putting on. Is that correct?
That's correct.
I also had asked you to empty your bladder, which you did.
Yes.
I checked your height, which is 6 feet 2 inches. Your weight is 195 pounds. Is that correct?
That's right.
I also checked your vital signs. The blood pressure I got was 138/80. Pulse was 88. Respiration was 18, and temperature was 98.8 degrees Fahrenheit. Is that correct?
That's correct.
Okay. Now we'll start with the head to toe assessment. First of all, I'll start with the inspection on the head and the face. The head is symmetrical. The skin is intact. I don't notice any lesions or any bruises. Skin is smooth, facial is broad. I'm not noticing any hair distribution on the skull. The face is symmetrical and well aligned with the skull. I'll go further with the inspection of the skull, with the palpation of the skull. We start from the front to the back. Palpating 4 masses, no depression. Bones of the skull are indistinguishable. I'll go down to the face. Palpate for the bones of the face. Bones of the face are intact. I'm not noticing any swelling or any inflammation. Do you feel any pain?
No.
Okay. Further down, I will assess for the palpate for the frontal sinuses. Do you feel pain?
No.
Skin or sinuses, do you feel any pain?
No.
The maxillary sinuses, do you feel any pain?
No.
Okay. Open your mouth for me. I'm going to assess the temporomandibular joint. Open it wider. I can assess it near the tragus of the ear. I don't notice any popping sounds or any crepitus. Okay. Could you smile for me? Clench your teeth for me. Clench your teeth again. I'm going to apply opposing force as you clench your teeth. Bring out your tongue for me. Push your tongue back. Frown your face. Like frown your face or wrinkle your forehead like that. Okay. Move your face this way and that way. Okay, do you feel any pain?
No.
No? Okay. Moving on, we'll go to assess the eyes. With assessing the eyes, we'll once again start with inspection of the eyebrows. The eyebrows are symmetrical and they don't extend beyond the orbit of the eyes. The hair is thick, black, and coarse. We'll also look at the eyes itself. Both of them are symmetrical with the eyelashes, which are thick and black. Could you look up for me? Look up for me. I'm trying to assess the conjunctiva. I don't notice any swelling. I'll also palpate the lacrimal gland. I'm not noticing any puffiness. I'll assess, palpate the muzzle of the eyes. Do you feel any pain?
No.
No tremors, no fasciculations noted, and no edema noted. Next, we'll move on to the near visual screen. I'll have you close one eye.
With this?
Yes, with this. Close one eye and read, the lowest line. Can you say
The lowest word? AMOTWVX.
Did you close the eye? Close the eye. Yeah. Read the lowest line.
AMOTWUVX.
Okay. Do it with the other eye, please. Close it well.
AMOTWVX.
Which means you have 6 to 5 vision. Thank you very much. We'll go ahead and do the cover and uncover test. Just look at the spot over there. You can look at that picture while I cover this eye. As I'm doing the cover and uncover test, I'm assessing for deviation of the eyes when I remove the cover. I'll do it on this eye also and see if the other eye will deviate, uncovered eye will deviate. No deviations noted, eyes are intact. I'll go further and assess the eyes too. Right now I'm assessing to see how the pupils will react to light. I also assess the other eye. Pupils are reactive, equal, round to light and accommodation. And I'll go further down now. We're moving to still at the eyes. Now I'll assess visual fields. Close this eye, that part of your eye. These two fingers, tell me if you see them, okay?
Yes.
Do you see it? Do you see it?
Yes.
Okay. Do you see it?
Yes.
Do you see it? I'm assessing patient's visual
Yes.
fields. We do with the other eye too. Do you see my fingers?
Yes.
How many do you see wrinkling?
2.
Okay. From this side also, do you see them?
2.
Do you see them?
2 fingers.
Okay. Now we'll go further and assess for the extraoculometer movements, and we're going to assess for the 6 cardinal fields of gaze. You can do the same thing. Close your eye. You close your eye. One eye at a time. Okay? And I'll start from the middle point. Let me get a blue pen. Tell me, just look at the tip and see if you see the blue point, okay? Start from the middle. Superior, do you see it?
Yes.
Do you see it?
Blue point, yes.
Okay. Do you see it?
Yes.
Do you see it?
Yes.
Do you see it?
Yes.
After our position, do you see it?
Yes.
Okay. Cover the other eye and we'll go through the same fields again. It's cardinal 6 cardinal fields of vision. Do you see it?
Yes.
Blue point. Yes.
Yes. Yes. Yes. Yes. Yes.
Okay. Fields of gaze are intact for the patient. Now we'll move on to the nose. And as usual, we start with inspection of the nose. The nose is midline. Bone structure is good, not deviated. I'm not noticing any bruises on the nose. Skin is intact. And I'll palpate the nose. You can still palpate for the maxillary sinuses and sphenosinuses. No lesions, no dead, no masses. I'll occlude one nose and tell the patient to breathe. Because I'm assessing to see if the nails are patent. Breathe in, take a deep breath. Breathe in, take a deep breath. Nails are patent. I don't notice any nasal quality to breathe in. Next, I'll use my light. I'll look inside the nails. Tilt your head up a little bit. And I'm assessing to see the septum. Septum is not deviated. Septum is midline. The anterior wall is thicker than the posterior septum. I'm also looking at the turbinates. The inner turbinates and the midline turbinates are present and pink in color. No swelling, no lesions noted. And we'll continue further, and we'll go to the lips. First of all, as usual, we'll start with the inspection of the lips. The lips are supple. I don't notice any cracked skin. I don't notice any cracked skin. And go and look inside the mouth. Could you open your mouth for me? With the light, I can assess the mouth. Open it wider, please. Okay. Patient has good dentition. The teeth is all white. I don't notice any lesions. So move your tongue for me up to the up. I'm trying to assess the soft palate and the hard palate, which is intact. Move your tongue side to side. I don't notice any lesions. I'm going to depress your tongue a little bit because I'm looking for the uvula. The uvula is present. The tonsils are present and pink, no swelling. I'm going to say ah for me. Ah, okay. I'm going to assess the gag reflex. Gag reflex is intact. Moving on, we'll assess the ears. The patient has 2 ears. Ears are symmetrical and well aligned to the head. Then I'll palpate the auricles. The auricles are firm yet mobile. Folded back, they can retract easily back to the former position. I don't notice any drainages in the ears. No drainages in the ears. I'm not noticing any extra skin tag or any extra or any masses or inflammation. Do you feel any pain?
No.
No pain, okay. Then we do the whisper test. I'm going to stand like 5 feet from you and whisper and tell me if you hear it. 3T9.
Yes.
Can you repeat what I said?
3T9.
Okay, I'm going to go do it with the other ear. About 2 to 5 feet from the patient. ABC. ABC.
ABC.
Okay. Patient's ears are intact. First of all, next I will do the Weber test. If I have the tuning fork, I will hold the stem and touch the tines so that it will vibrate. Put it on the midline head of the patient and ask the patient if he can hear the sounds. This is assessing for unilateral hearing loss. The patient should be able to hear the sounds equally bilateral in both ears. Next will be the Rhine test with the same tuning fork. I will strike the Rhine, put it behind the mouth process, ask the patient to see if they can hear it. And this is assessing for the bone and air conduction. Also strike the tines again, put it in front of the auricle, and ask the patient if they can hear it. Still assessing for bone and air conduction. What I did here is also what I'll do on the other ear. First, strike it, put it behind the massage process, and ask the patient if he can hear the sound. Strike the tines again, put it in front of the auricle, and ask the patient if they can hear it until it stops. This is assessing for air and bone conduction. The air should be twice as long as the bone conduction. Now we're moving on down to the neck. As usual, we start with inspection. Neck is symmetrical and aligned to the head. The skin is intact. I don't notice any bruises or any lesions. And then we'll go with palpation of the neck. Palpate the carotid arteries one at a time. Two plus pulses. I'll also go behind the patient. First of all, I'll palpate for the trachea. Trachea is midline. Okay, I'll go behind the patient and I'll palpate for the thyroid. Could you take a swallow for me? As I'm palpating the thyroid, I'm feeling the cryoid bone and the cryoid cartilage, thyroid cartilage, and the hyoid bone. And as the patient swallows, I can feel them moving through my fingers, and they are not swollen. I don't notice any swelling. Do you feel any pain?
No.
Okay. Next, still at the neck, we can do some range of motion. I'll ask you to move your neck that way. Okay. This way. We'll apply opposing force. This way again. Back. Down. There's resistance to the neck. See if you can move it a little bit further. Okay, to the side. I will take to that side. Okay, shrug your shoulders for me. Shrug your shoulders like that. I'll apply resistance. Okay. I'm checking for cranial nerves. Next, we'll move on to the upper extremities. The upper extremities, we are going to assess the posterior, the anterior, and the lateral posture of the patient. First, we can start with the hands. The two hands are equal bilaterally. The skin is intact. Hair distribution is even. And I can palpate the hands. Palpating the hands. I don't notice any lesions. Look at the fingers. Digits are equal. 10 fingers. No discoloration. Look at the palm and the dorsal surfaces. No abnormals noted. While I'm still over here, I can go ahead and assess the lymph nodes. First, we start with the preauricular lymph nodes, post-auricular lymph nodes, the occipital lymph nodes, the tonsillar lymph nodes, submandibular lymph nodes, submental lymph nodes, superficial cervical lymph nodes, posterior cervical lymph nodes, deep cervical lymph nodes. Can you take a deep breath and assess the supraclavicular lymph nodes? None of them is palpable and no mass is noted. Then I'll move on to, still in front of the patient on the upper extremities. We'll assess the pulses. I'll assess bilaterally to make sure they are equal. This is the brachial pulse of the patient. I will move on to the radial pulse. Pulse is +2, which is an expected finding. Let's do a little bit of a range of motion. Spread your arms for me. I'm going to apply some force. Put your hands in front of me. Resistance is there. Cross your hands around you, behind you. Range of motion is intact. And we'll go further to auscultating the carotid and the thyroid pulses. And in auscultating the carotid, we're looking for breathing, deep breath, hold it, deep breath. No breathing on it. I can also auscultate for the thyroid. No breathing on it. Now we'll go down to the posterior. And as usual, we'll start with inspection. There is ease of breathing. Skin is intact. There is ease of breathing. Take a deep breath. And the posterior area aligns with the patient's breathing. And then we'll go further with palpation. Can I move your shirt a little bit?
Sure.
We're going to palpate the back, the posterior. Take a deep breath. And we're palpating for tactile trematose. Tactile trematose. None is present. Can also assess for thoracic expansion as the patient is from the 10th rib up. As the patient is breathing, there is thoracic expansion present, which I can assess with my 2 thumbs. Thoracic expansion is present. Next, we will percuss the lung fields. And as we percuss the lung fields, we're looking for consolidation. Start with all lung field areas. Percussing the lung fields, looking for consolidation. None noted. Next, we will auscultate the lung fields of the patient. I'm going to listen to your lung fills. Please, I'd like you to take a deep breath. When I say start, you say 99E and whisper the last 99. In auscultating the lung fills, I'm looking for vocophony, egophony, and whispered ventriloquy. Okay, go ahead.
99E. 99E.
Taking a deep breath.
99E.
99.
99E. 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 99E.
Okay. All fields are clear to us, Caucasian. Next, we'll move to the anterior area of the patient. Could you raise your hands up? I can also listen to the lung field area. Say 99E, 99.
99E, 99. 99E, 99. 99E, 99. 99E, 99.
And as usual, we'll start with we'll start with inspection. Inspecting the anterior chest, skin is intact. I'm not noticing any pulsations or any heaving. Look up for me. No lesions noted. Hair distribution is equal. We'll still continue with the lung fields. First, we'll palpate the lung fields, and we're looking for tactile parameters. Could I raise this up a little bit? I don't notice any tactile parameters. We'll auscultate the lung fields, looking for consolidation. No consolidation noticed. First, we'll auscultate the lung fields. Take a deep breath and say 99E, 99. Deep breath.
99E, 99. 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 99E, 99E, 99. 99E, 99.
Okay. Lung fields are clear. Next, we'll assess the heart. Looking to see, as usual, we start with inspection. Looking to see if we are seeing any pulsations, any heaving, which is not noticeable. Skin is intact, hair distribution is even. Then we palpate the heart. First, I'll palpate for the apex of the heart. Go to the sternal body. See if I can feel any pulsations. At the apex of the heart, you can hear the heartbeat. You can feel for the heartbeat. Left sternal body, see if you can feel for any pulsations or any heaving. I don't notice any heaving. And also palpate for the base of the heart. I don't feel any heaving. Then next we focus on the heart, trying to see if we can at least have an idea of the size of the heart. Start from up there, little up, focus outwards. Trying to feel for the position of the heart. Okay, that's done. We'll go ahead and assess the 5 cardiac areas of the heart. Listen to the 5 cardiac areas of the heart. First of all, we'll start with the right second sternal border, where you have the aortic. And I'll listen to it. Left sternal border, where you have the pulmonic. Go down to the Erb's point, third left sternal body, intercostal body, go down to the tricuspid, and the fifth intercostal space with the bell of the stethoscope is where we have the apex of the heart. That's the mitral. Now, as I'm assessing, listening to the heart, I'm assessing for, see if I can hear S1, S2, S3, S4, any moments. Heart sounds are distinct and regular. I was able to hear S1 and S2. Moving on, we'll go further now, and could you lie down for me? Now I'm going
Back on my
to,
stomach.
yes, lie down. I'm going to assess for the jugular vein distension. If I could raise this, I'll raise it up to 45-degree angle. When it's raised on a 45-degree angle, the jugular vein is more extended. I can assess if the patient has a jugular vein distension, and we can also measure the jugular vein. I'll need 2 rulers, 15 cm each. Place the first ruler around the mid-axillary line at the position of the nipple. Will be that way, vertical position. Place the second ruler towards the JVP, meningos of the JVP, at a horizontal angle from the point of the vertical ruler. And I'll measure the vertical line over the heart. Normal JVP measurement should be below 9 cm of water. The patient doesn't have any jugular vein distension. Now, still lying down, we'll go down to the stomach. Can I open the abdomen area? Can I open your shirt a little bit?
Why not?
Okay. And as usual, we'll start with inspection. For the inspection of the stomach, it's best done with me sitting at the right side of the patient. This is your left side. Okay, it would have been the other side, but we don't have enough space. At the right side of the patient, I'll sit at the right side and notice for, I'm looking for contour, for surface motion movement. I'm noticing to see if there's any distension, which there's no distension. Next, I'll go with auscultating. Hair is evenly distributed. Auscultate, first of all, the quadrants of the abdomen. These are the lower quadrants, and I'm listening for vowel sounds. Next, I'll auscultate for the arteries. The aortic artery, the renal artery on both sides, the iliac artery, and the femoral artery, somewhere down there. All sounds are present times 4 quadrants. Next, arteries are also, the pulses are +2, which is a normal finding. Next, I'll go further to across the abdomen. Start with the quadrants. Should have a tympanic sound, which is a normal finding. Then I'll go over to the right side of the patient to see if I can have an idea of where the ear is. I'll start with the mid-clavicular line, start percussing from the tympanic area up to the area of dullness. Once I get to the area of dullness, that should be the lower margin of the liver. I go up from here, from the mid-clavicular line, from the upper region, going down to the area of dullness, and this should be the upper margin of the liver. If measured, the liver should be about 6 cm. A normal liver should be 6 cm to 12 cm. If it's more than that, then the liver is inflamed and it's an abnormal finding. I will also also go to the other side of the patient, which is the left side, and see if I can percuss for the spleen. Have an idea of how big the spleen is. I'll start from the mid-axillary line to percuss. Goes down to the abdomen. And I start from the mid-clavicular line across to the last intercostal space. And that should be the spleen. The spleen should be tympanitic in sound, which I feel. So it's not swollen or anything. I don't feel any masses. Next, we'll go on with the light palpation. I'll start with quadrants of the stomach. This is light palpation. And then deep palpation. See, my hands are going deeper and I'm looking for masses. Do you feel any pain?
No.
No masses, no dead, no lesions, no swelling, no distension. Now go to the right costal margin. I'm trying to palpate the liver. And bring the liver up to me at the right costal margin. The liver is non-palpable. At the same time, I can also palpate to see if I can palpate the gallbladder, which is non-palpable. A palpable gallbladder is an abnormal finding. I can also reach over with my hand behind the patient, see if I can palpate for the spleen. No, the spleen is non-palpable. A palpable spleen is an abnormal finding, meaning that the spleen is swollen. Go down to the left flank, see if I can palpate the kidneys. No, not able to palpate the kidneys, no masses noted. Go down to the right side of the patient. My hand is on the left flank, on the right flank. See if I can palpate the kidneys. No kidneys noted. Next, we'll go on to the lower extremities of the patient. Stretch your legs for me. 2 legs are equal, head distribution is even, skin is intact, no bruises noted. I'm going to test the strength. Muscle tone is good. I'm going to squeeze and push. Strength is equal bilaterally. Then I'll assess for the pulses. The popliteal pulse. The dorsalis pulse. Bilateral. And the posterior tibial pulse. Pulse is +2. I can also assess for capillary refill, which is less than 2 seconds. Then I'll do light sensation. Do you feel this? This is light. Do you feel it?
Yes.
Do you feel it?
Yes.
I can also test the light sensation over here. Do you feel it?
Yes.
Here?
Yes.
Here?
Yes.
Here?
Yes.
Okay. At the same time, I can assess for sharp sensation on the legs. Tell me if this is sharp. Do you feel it?
Yes.
Do you feel that?
Yes.
Okay. Could you stand up for me? Not stand up, sit up a little bit for me. Sit up a little bit for me. And then I'll go ahead and practice for the CVA, coastal vertebral angle, at the back of the patient. Because you feel pain?
No.
You feel pain?
No.
Okay. No pain noted in the CVA angle. Now, during my assessment, I was able to assess most of the cranial nerves, but I'll just have a run through of the cranial nerve. Cranial nerve 1 is olfactory, where I would have introduce different odors to the patient and see if you can differentiate the sense of smell. Cranial nerve 2 is optic, which I did with the Snellen chart to assess visual acuity. Cranial nerve 3 is the oculometer, which I did with visual field assessment, assessing the peripheral and central vision. Cranial nerve 4 is trochlear, which I assessed with assessing for eyelids, ptosis, see if he can close his eyelids and open his eyelids. Cranial nerve 5 is trigeminal, which I did with asking the patient to clench his teeth, and while I was palpating the jaw and applying and there was resistance. Cranial nerve 6 is abducens, which I did with the light, assessing for pupils if they are round, equal, reactive to light and accommodation. Cranial nerve 7 is facial, which I assess with the facial assessments of the patient. I can also assess cranial nerve 7 with introducing a sweet salty taste, and see if the patient can differentiate the two. Cranial nerve 8 is acoustic, which I did with the whisper test and the Rhine test, the bone and air conduction test, and also assessing for unilateral hearing loss, that's a Weber test. Cranial nerve 9 is the glossopharyngeal, and I would have had different sour and bitter taste and see if the patient can differentiate the taste. Cranial nerve 10 is the vagus nerve, which I assessed with the gap reflex, which is intact. Cranial nerve 11 is the spinal accessory, where I had the patient shrug his shoulders against resistance. And the last cranial nerve, which is cranial nerve 12, is the hypoglossal nerve, where I had the patient stick out his tongue and assessed with looking for symmetry and assessment of the chin against resistance. Thank you very much for watching my head-to-toe assessment. Thank you.